For years, I've ordered MRI after MRI for hip pain, reviewed the findings, and made surgical recommendations based on what the imaging showed. I thought I was being thorough, but I wasn't. I was missing the most important part of the picture. And if you've been handed an MRI report and told you have a labral tear, a cam deformity, and you've been trying to figure out what to do next, I want you to pay attention to what I'm about to say. After performing 2,000 hip procedures and seeing more than 15,000 patients with hip-related disorders in my practice and in training, I started noticing a pattern I just couldn't ignore. Patients who looked straightforward on imaging were sometimes the most complex to treat. And patients with alarming MRI findings sometimes needed far less intervention than the report suggested. But what I didn't expect was the specific moment that forced me to rethink the role imaging was playing in my decision-making entirely. And what I realized then is something that I now believe every hip patient needs to understand before they agree to any treatment. I'm going to walk you through what I used to do, why I stopped, and what I now rely on instead. By the end of this, you'll understand why two patients with identical MRI reports can need completely different treatments and how to make sure you're being treated for the right problem. Point number one, what I used to rely on and why it made sense. Listen, I used to let the MRI guide the conversation. The MRI is objective. It's detailed. It tells you what's there. And so I trusted it. Medical school trains you to correlate symptoms with imaging. You learn what a labral tear looks like on MRI, what a cam deformity looks like, what impingement patterns look like, and so you develop a reflex. Imaging shows X, patient has Y symptoms, therefore treat X. It felt logical. It feels evidence-based. And for some patients, it absolutely is. The problem is that MRIs are extraordinarily good at showing you what's structurally present in the joint. However, they're far less reliable at telling you whether that finding is the actual cause of someone's pain. A finding on imaging is not automatically telling you what's causing the pain. And that gap between what's on the film and what's driving the symptoms is where patients can get lost. Hear me out. A normal MRI does not mean a normal hip, and an abnormal MRI does not mean that the abnormality is the problem. I have operated on patients who had findings that looked clear on imaging, and they still had pain afterwards, because the real driver was in fact never identified. And I want to be clear, I'm not criticizing anyone who practices this way. I practice this way. The imaging is real, the findings are real, and the intention is always to help. The issue is not bad faith. It's a framework that has a specific and predictable gap in it. And once you see that gap, you cannot unsee it. And what I started noticing over hundreds of cases was a pattern of outcomes that should have been simple and wasn't. And that pattern is what we need to talk about next. Point number two, what imaging first was actually producing. When I reviewed an MRI and I saw labral tear or significant impingement, my expectation was that addressing those findings would resolve the symptoms. That was the premise. Treat the imaging, relieve the pain. What I kept seeing and what took volume to recognize was that some patients who had clear findings addressed surgically were still symptomatic afterwards. And not because the surgery was poorly executed, but it was because the structural finding on the MRI was not actually the primary driver of their pain. There was something else going on. A muscle problem, a tendon problem, a spinal source, referred pain, a pattern of muscle weakness. And we had treated the image instead of the patient. I also saw the reverse. Patients with MRI findings that looked minor or even borderline, but then who turned out to have significant impingement that was absolutely driving their symptoms, something the clinical picture only made obvious once I examined them properly. And so you can treat a perfect MRI result and still have a patient who doesn't get better. And you can see a modest finding on film and be looking at someone who absolutely needs surgery. Imaging shows what's there. It doesn't tell you what matters. And there were two specific cases that made this impossible to ignore. And it happened in a way I didn't expect. If you're finding this useful, subscribe so you don't miss the next video. I'm going to go deeper into what a proper hip diagnosis actually looks like and what questions you should be asking before any treatment decision. Link is below. Point three, the moment it broke. I had a patient, I'll call her Sarah. She was 14 years old and had been seen at a children's hospital for persistent hip pain. Her MRI had been reviewed and she had undergone multiple evaluations. And the conclusion from several providers was that there was nothing structurally wrong with her hip. She was then diagnosed with something called amplified musculoskeletal pain syndrome and was started on chronic pain medicine. When I met her, something just didn't quite fit. Her pain was very reproducible with specific hip movements, and the pattern of symptoms seemed to point back to the hip joint itself, no matter what. That didn't mean that she needed surgery, but it did make me question whether we had the right diagnosis. And so rather relying on the normal MRI alone, we performed a diagnostic hip injection. And her response was dramatic when she had significant temporary pain relief. Therefore, this confirmed that the joint was a primary source of her symptoms. And at that point, her history, her exam, her imaging, and the injection response were all pointing in the same direction. She underwent hip arthroscopy. The findings that we saw during surgery matched what we expected clinically, and then she went on to recover well and return to normal activities. What stayed with me here wasn't just that she improved, it was how easily the diagnosis could have been missed if we had accepted the MRI interpretation as the final answer. Here's another case that reinforced this lesson. I remember another patient, this time a 21-year-old female, who came in with hip and glute pain. At first glance, she looked like a fairly typical hip impingement patient. Her imaging showed cam-type anatomy, albeit it was mild. Her MRI had findings that could certainly point you towards the hip. On a physical examination, she had some signs that suggested FAI or hip impingement. Had I only looked at the MRI and the anatomy, it would have been easy to conclude that the hip arthroscopy was the best next step. But something just didn't quite fit. The location of her pain wasn't classic, the pattern of her symptoms wasn't quite right, and the overall story felt different to many of the impingement patients that I typically see. And so before making any surgical decisions, we performed a diagnostic hip injection. And what happened next was very informative. Not only did the injection fail to improve her symptoms, she actually felt worse afterwards. That immediately raised a red flag for me, because if the hip joint was truly the primary source of the pain in that instance, I would have expected at least some temporary pain relief from the anesthetic in that injection. Instead, we had a positive MRI, but a negative diagnostic injection. At that point, we stepped back and looked at the entire picture again. As we dug deeper into her history, we learned that she had significant pelvic floor symptoms, including urinary urgency, frequency, pelvic pain that necessitated ultrasounds of the bladder and pelvis. Those symptoms just didn't fit neatly into hip impingement diagnosis. And the more we talked, the more it became clear that something else was likely driving the majority of her symptoms. I explained to her mother that while the MRI findings were real, they may not be the reason her daughter was hurting. And that was not an easy conversation, trust me. Because like many patients, her mother wanted a clear answer. She wanted to fix the abnormality on the MRI. And understandably, she was hesitant to hear that the recommendation was going to involve more physical therapy. But this wasn't simply more PT. This was pelvic floor PT, a program targeting a completely different system than what she had been addressed previously. Fortunately, they trusted the process. She started pelvic floor PT, and over time, both her pelvic symptoms and her hip impingement significantly improved. And in the end, really everyone was relieved that we didn't proceed with surgery simply because the MRI happened to be positive. For me, that case reinforced something I now think about almost every day. An MRI can tell you what's present, but it cannot tell you by itself what is responsible for the pain. That's why the history, the physical exam, and sometimes the response to a diagnostic injection are just as important as the imaging itself. And so sometimes the hardest thing to do as a surgeon is not deciding when to operate, it's deciding when not to. So ask yourself these three things right now. When you got your MRI results, did anyone walk you through how the imaging findings matched with your specific symptoms in your physical exam? Or did the report mostly speak for itself? Have you been told your MRI is quote unquote normal or unremarkable, but you still have pain that limits what you can do? Or have you been told your MRI shows something significant and now you're planning treatment based almost entirely on that report? If you answered yes to any of those, it doesn't mean your treatment plan is wrong, but it does mean that we might have been missing a step between the imaging and the recommendation that could determine whether what you're about to do actually addresses the right problem. And that step is what changed how I practice. And that's what I want to share with you now. Point number 4. Here's what I now believe instead. The MRI is one input among several, not the conclusion. If you've been handed a treatment recommendation based primarily on imaging, you are entitled to ask how the findings on that report correlate with your exam and your specific symptoms. Because if the answer is they match perfectly and here's how, that's a good sign. If the answer is mostly just the report itself, that's a gap worth closing before you commit to anything. And after Sarah's case, I formalized something I had been doing informally, a diagnostic injection as a confirmatory step before surgery. And so before surgery, we inject the numbing agent directly into the hip joint under ultrasound guidance. If the pain in the hip improves significantly for the duration of the injection, it confirms that the joint is the primary source of the pain. If it doesn't, we need to look elsewhere, whether it's the spine, the pelvic floor, the core muscle, or somewhere else entirely. And that single step has redirected care for a meaningful number of patients who would otherwise have had the wrong procedure. Here's one concrete thing you can do right now before your next appointment that puts you in a significantly better position regardless of what your imaging shows. What I tell every patient now, the reason imaging first frameworks create avoidable problems is that they skip the step of confirming the pain generator. Hip pain is often multifactorial, meaning there can be more than one thing contributing to the pain. A structural finding might be present and be real, but still not be the primary driver. The clinical exam and your symptoms and how they correlate are telling you which layer is running the show. And so if you treat the wrong layer, you don't get better. An MRI of your hip is like a photograph of your car's engine with the hood up. It shows you exactly what's in there. But if your car is making noise and you're trying to figure out where it's coming from, you don't just look at the photo and start replacing parts. You run the engine, you listen, you test specific components. The photo tells you what exists. The examination tells you what's causing the problem. One without the other is an incomplete diagnosis. And what changes when this step is in place is simple. The thing you're treating is actually the thing that's causing your pain. And that sounds obvious. Unfortunately, in practice, it's not always how care unfolds. And understanding that you can ask for this level of clarity before committing to any intervention puts you in a completely different position. And so before your next appointment, do these 4 things. You take less than 10 minutes and will change the quality of every conversation you have with any hip specialist going forward. Write down exactly where your pain is, not just your hip, but be specific. Is it the front of your hip, your groin? Is it under your hip? Is it deep in the joint? Does it radiate down your leg? The location is a clinical clue. Write down what makes it worse and what makes it better. Loading the hip in certain positions, sitting for long periods, specific movements, rest. That pattern is information that no MRI can give. Write down what you've already tried and how each one affected your symptoms. PT, injections, activity modification, rest. The response history matters here. And before agreeing to any next step, whether it's imaging, injection, or surgery, please ask this one question. Based on my exam today, how confident are you that what's on my MRI is actually causing my pain? The answer to that question will tell you a great deal about whether you're in the right hands. In conclusion, I started this video by telling you that for years, I trusted imaging more than I should have. That's a hard thing to say publicly, and I say it because you deserve to hear it. The MRI is a powerful tool, but it's not the diagnosis on its own. The practitioners who get the best outcomes are the ones who use it as one input among several and who don't commit to a treatment plan until the picture is complete. You now have the same framework that I use. Use it at your next appointment. It might be the most important question that you ask. If this video helped you think about your hip pain differently, the next video covers exactly what a proper hip evaluation should look like from start to finish. What gets examined, what questions should be asked, and what a complete diagnosis actually involves before any treatment plan begins. Link is on the end screen and in the description. I'll see you there.